I want to welcome everyone to the Military Personnel Subcommittee's hearing on military health system reform for pain management, opioids prescriptions management, and reporting transparency. Our panel includes the Director of the Defense Health Agency and the Director of Mental Health Policy and Oversight for the Assistant Secretary of Defense for Health Affairs. They are here to address opioid abuse, an important problem that has affected every congressional district in the United States. The opioid epidemic in the United States claims roughly 116 people from drug overdoses every day. 42,249 people died from overdosing on opioids in 2016, with an estimated cost of over $504 billion. With the military being a vital subset of the overall population that may encounter stresses related to deployment, training, and family separations, understanding the magnitude of opioid abuse and the challenges related to overall pain management is a critical part of the Military Personnel Subcommittee's congressional oversight efforts. We are here today to understand the scope of the opioid abuse issues in the military and with non-active duty TRICARE beneficiaries. Our panel will also address policy reform on opioids from a strategic enterprise perspective and the Department of Defense model for pain management. The subcommittee is also concerned with the Department of Defense's efforts to ensure reporting transparency and with state prescription drug monitoring programs. We understand there have been some challenges with developing a state prescription drug monitoring programs, PDMPSs, model that balances military-related cybersecurity and operational concerns with the need for data transparency with non-military treatment facility clinicians and pharmacists that are serving TRICARE beneficiaries accessing multiple points of healthcare services. I ask unanimous consent that non-subcommittee members be allowed to participate in today's briefing after all subcommittee members have had an opportunity to ask questions. Is there objection? Without objection, subcommittee's members will be recognized at the appropriate time for 5 minutes. Before I introduce our panel, let me offer Congresswoman Spear an opportunity to make any opening remarks.
Mr. Chairman, thank you. And I'm delighted that after a couple of opportunities to have this hearing that had to be postponed, we welcome our individuals who are testifying today. And I want to thank the chairman for having this hearing, because indeed it is a crisis in our country. When we have over 2 million people over the age of 12 who are either dependent on opioids or are abusing them, it is time for us to take very seriously the impacts on everyone, and none the least our service members, their dependents, and retirees. I think the military has the opportunity to lead the nation to reduce opioid abuse and develop alternative pain management therapies. And today I'm eager to hear about your efforts to exercise such leadership. Several years ago, the military realized it had an opioid problem when it became clear that the predominant pain treatment for our wounded warriors was prescription medication. Changing prescribing practices and increasing the use of alternative pain management methods has enabled the military to reduce the prescription opioid abuse among active duty service members to 1%. However, opioid abuse remains a challenge, especially for retirees and dependents. I'm interested in hearing how the department's new opioid prescription guidance will be implemented to limit the amount of days for each prescription, as well as how the DHA will implement it if it becomes law. The NDAA requirement to create a prescription drug monitoring program to increase transparency with states, as well as reduce prescription monitoring. I'm also interested in hearing about how DHA will lead research on and increase the availability of alternative pain methods like acupuncture, chiropractic care, and other services that are now being utilized by healthcare providers around the country. So with that, Mr. Chairman, I yield back.
Thank you, Ranking Member Spear. We will give each witness the opportunity to present his or her testimony, and each member an opportunity to question the witnesses for 5 minutes. We would also respectfully remind the witnesses to summarize to the greatest extent possible the high points of your written testimony in 5 minutes or less. Your written comments and statements will be made part of the hearing record. Let me welcome our panel: Vice Admiral Raquel C. Bono, Medical Corps, United States Navy, Director, Defense Health Agency, and Captain Mike Colston, Medical Corps, United States Navy, Director of Mental Health Policy and Oversight Office of the Assistant Secretary of Defense for Health Affairs. Vice Admiral Bono, you are now recognized for 5 minutes.
Thank you, sir. Chairman Kaufman, Ranking Member Spear, and members of the subcommittee, I'm honored here to be alongside with Captain Colston, who serves as our senior clinical policy expert for DoD on issues related to pain management and opioid abuse issues. I want to thank the committee for your continued support and investments in pain management research and opioid addiction. The military health system's mission is to ensure the medical readiness of our nation's armed forces and to provide world-class health care for all of our 9.4 million beneficiaries. The military health system is also part of the larger U.S. health system, and we have a shared responsibility to take action and help address the nation's public health crisis regarding opioid abuse and addiction. Today, what I'd like to do is outline what we know about the current state of opioid issues and addiction among DoD beneficiaries, highlight the steps the department is taking to address this crisis, describe the partnerships we've built across the public and private sectors, and finally, to describe our efforts to enhance our ability to share our data on our beneficiaries with state prescription drug monitoring programs. The department has made strides in managing opioid abuse within our system and is continuously looking to further enhance our programs. Fewer than 1% of our active duty forces either abuse or are addicted to opioids, and our overdose death rate among active duty is 1/4 the national average. Chronic opioid use is more common among our patients who are 45 years or older. They are more likely to be retirees or family members of retirees, and they receive the majority of their care outside of our military hospitals and clinics. Just last week, the department published the Defense Health Agency Procedural Instruction for Pain Management and Opioid Safety, which establishes the MHS stepped care model as the comprehensive, standardized pain management framework for providing consistent, quality, and safe care for patients with pain, with an emphasis on non-pharmacologic therapies. With the help of this model, we have reduced opioid prescriptions by 15%. We plan to further reduce this rate through a focus on non-pharmacologic therapies within the military treatment facilities and through direct care policy changes. Working closely with our pharmacy contractor, Express Scripts Incorporated, ESI, we are closely monitoring the distribution of opioids across all venues: military pharmacies, civilian retail pharmacies, and our mail order system. We are identifying high users of opioids and sharing that information with our providers within the military treatment facilities. We've also taken measures to minimize complications for patients requiring opioids. We are able to monitor the daily morphine intake of those patients requiring opioid therapy and easily identify those at increased risk for death from opioids. We have a patient lookup tool that calculates the risk of overdose or serious opioid-induced respiratory depression to assist providers in safe opioid prescribing. Naloxone is readily available through the pharmacy in the military treatment facilities to be dispensed to eligible beneficiaries upon beneficiary request or when the pharmacist determines elevated risk for life-threatening opiate overdose using the patient lookup tool. In addition, the new TRICARE managed care contracts require our contract partners to act on information provided by DoD on a quarterly basis regarding patients with unusually high or lengthy opioid use, as well as providers who prescribe high amounts of opioids. And we've been working with ESI to establish a prescription drug monitoring program, PDMP, that will connect with the states. This provides a key tool in the opioid fight, as it will allow DoD providers to access state PDMPs as well as allow civilian providers to access the DoD PDMP. Although prescriptions filled for DoD beneficiaries through the mail or retail venues are readily reported to the states, the establishment of the DoD PDMP will provide a full controlled substance profile for all providers and pharmacists. Our DoD PDMP solution will operate through a commercially available portal and hub technology that not only allows us to bidirectionally share DoD-controlled substance information with the state, but addresses operational security concerns. I expect this new capability to be available by December 2018. Mr. Chairman, Madam Ranking Member, this crisis is touching the lives of so many of our fellow citizens, and the Department is committed to playing its part to help combat the epidemic and ensure our patients receive the finest care we can provide. DoD is making headway, but there's more to be done in educating our patients and providers on threats from opioid addiction and strategies to reduce abuse. Thank you for asking us to be here today. Between myself and Captain Colston, who's deeply involved in this issue day to day, I look forward to addressing all of your questions. Thank you.
Thank you, Admiral Bono. How is the Department of Defense planning to ensure compliance and transparency reporting with the state prescription drug monitoring programs? And how do we know this is the right model?
Sir, this is a model that's been in use by many of the states, and so with what we're doing with making our data available to the state PDMPs is by adhering to their practices and their requirements for participation. It is bidirectional, and so we have found a way to make sure that our data is completely visible to them.
Okay, Admiral Bono or Captain Colston, what steps or processes are we putting in place to wean service members off of opioids, and is this tracked across the military health system?
Yes, sir, it is. So, in fact, opiate use is down even over the last year in active duty service members from 3.2% to 2.7%. We have introduced a stepped care model with regard to the way that we treat pain that puts an emphasis on non-pharmacologic therapy and wants to take people off of opiates. We want acute pain not to become chronic pain, and we want to be able to treat both acute and chronic pain without opiates. There are several methods to detox someone from opiates that we approach clinically, and of course, for folks who struggle with both pain disorders and opiate use disorders, we have a full suite of medication-assisted therapy available both in network and in MTFs.
Okay, Admiral Bono, anything to add to that? No.
Yes, sir, this is very comprehensive, and Captain Colston described it well.
Very well, Admiral Bono. Are we considering healthcare industry best practices when it comes to management of opioids? Please provide some examples.
Yes, sir. Yes, as a matter of fact, the step care model that we're using was done in partnership with the VA and was validated with them. We are also working with NIH, and we're also working with West Virginia. And part of the research that we've been able to do is not only collaborate across these institutions, but also validate that the tools that we're using are effective. The pain scale that we use, the Defense Veterans Pain Scale, is something that we've done in partnership with the VA. So many of the tools that you see in use here have not only been done with best practices in the civilian and academic centers, but it's been validated by them as well.
Thank you, Admiral Bono. Ranking Member Spear.
Thank you, Mr. Chairman. Thank you, Admiral. And Captain, I'd like to spend a little time on the CDC guidelines. The CDC guidelines recommend immediate release of opioids, not extended. They recommend less than 3 days supply and suggest that 7 days will rarely be needed, and not to allow the use of benzodiazepines at the same time. So that's the recommendations by the CDC, and I'm wondering why your recommendations, your guidelines, are frankly much more liberal than that. Mm-hmm. In fact, I believe you have 7 days as your floor, which to me is more than twice what is being recommended by CDC.
So for minor procedures and acute pain, we actually recommend 5. And we also are looking at the morphine milligram equivalent to keep that below 90 per day. In that case, too, for acute and minor procedures, there can only be a refill on that prescription for 3 days, only if evaluated by a provider. For major procedures, we recommend 7 days, but again, refill can only be done after evaluation by a provider and with maintaining a morphine milligram equivalent below 90.
Well, you're not quite answering my question. Let me just read to you one of the other recommendations. It says that when considering increasing dosage to more than 50 morphine milligram equivalents per day and should avoid increasing dosage to 90 milligrams per day or carefully justify a decision to titrate dosage to 90 milligrams per day. I guess my point is that you're exceeding the guidelines in some ways significantly from what the CDC is recommending, and I want to know why.
While I'm familiar with the CDC guidelines, I think that what I was trying to share was how we stratified it between minor procedures and major procedures. And so I'd probably need to understand that a little bit more, and perhaps I might be missing something in the question, if I could.
Ask the captain?
Yes.
Okay.
One of my lifelines.
Ma'am, so most folks get much, much less than 50 morphine milligram equivalents per day. For dental procedures, it's 1 day with 1 day refill. For short-term pain or acute procedures or small procedures, it's 5 days with a 3-day refill. And again, most people don't get opiates at all for these types of procedures. For major procedures, 10 days with 7 days. I can tell you from personal experience, most of the time you don't get opiates. I just broke my foot in 4 places. I didn't get a shred of opiates. Recovered faster, felt much better. There is a consensus both between CDC and the VA DOD guidelines that we don't want to use opiates. We'd much rather use other modalities for pain. And if we are going to use a pharmacological approach, we want to use non-opiates. When you look at the amount of opiates that we are prescribing in the system, that number is down precipitously. And I have seen this evolve over the last 5 years.
Okay, I'm running out of time, so I think you've gotten my point. You might want to go back and look at whether you need to reduce it a little bit more. I have a subsequent question on, is it gabardine or gabber? Do you know what, doctor? Gabapentin.
Oh, gabapentin.
And are you using that in lieu of opioids, or is that considered?
Yes, ma'am. So gabapentin.
All right, can I just make a point there? Because I was just talking to a doctor because I'm about to have surgery, and he was saying now the abuse is shifting from opioids to this particular drug. So I think we should just be on the lookout that if we're just substituting one drug for another and it still has addictive qualities, that's a problem as well. But I would like to just shift gears for the little time that I've left to asking about this alternative pain management methods, the use of acupuncture, relaxation therapy, chiropractic care. Are there plans to expand these treatments to all MTFs? And if they are currently not available in MTFs, can beneficiary receive treatments in the civilian network?
Yes, ma'am. So 83% of our MTFs currently offer some kind of complementary modality. I am actively looking to see how we can make sure that all beneficiaries have availability or access to these complementary treatments, and have started studying how commercial and private plans are including this and what we can do to make sure that we have this in our health plan for all beneficiaries.
So you're saying in 80% you have at least one of these, but you may not have all of them. Is that what you're saying?
Yes, ma'am. At least one. There may be a combination, depending with acupuncture, meditation, and alternate pain treatment modalities.
And do you have that chilling system that many hospitals are now using in lieu of opioids?
I'm sorry.
There's some system where you can put a chilling I'm way above my pay grade. I think I'll just, I will yield back.
I'll Google it. If I'm,
Dr. Abraham?
Thank you, Mr. Chairman. If you guys are only got a 1% rate, you guys are phenomenally doing a great job, I can tell you, because we know compared to the civilian population, that's way below. So kudos to what you're doing. A couple of questions. And when you said there was a 15% reduction, is that in the young active troop, or is that in the troop that maybe has retired that has comorbid conditions such as arthritis, degenerative disc disease, or something like that?
these are primarily with the patients that are being treated on our MTFs.
Okay, so that's a young troop.
Yes, sir.
Okay, good deal. You mentioned naloxone, what we call Narcan,
Yes, sir.
and we know that that can be immediately life-saving. And it seems like the caregiver is able to access that if it's deemed necessary for that particular individual. Is that a correct statement?
Yes, sir.
Do you guys track the amount of Narcan that is used?
I just signed off on the policy that allows us to dispense the Narcan from our pharmacies, making that available to prescribers as well as pharmacists who have. So we are just now going to be able to start tracking that in real time.
Okay, and you said by April of 2019 or December of 2018, you'll be linking up with some of the states. Have you guys got a pilot program already in place?
December of 2018.
So this year?
Yes, sir. We'll
Okay.
be able to communicate with all state PDMPs.
And we have I'm from Louisiana, we have a pretty good reporting system there, and it does make a difference as far as, if I can punch up a patient and see that they're seeking from another physician, then, we go in and we have a little discussion with them.
Yes, sir. Our patient lookup tool allows providers like Captain Colston to look up day or night into the patient's profile. So that's been very helpful.
Okay, and, again, we understand the necessity of getting this right. We certainly understand the severity of the problem, not only in the military, but across the spectrum. Kudos to you, Captain, if you got 4 breaks and didn't take an opioid. So,
That's because
and we know,
we many days off.
And we probably rightly and maybe wrongly do vilify the opioid drug, but like any particular drug, used in the proper setting at the proper dose for the proper amount of time, it can be certainly, you don't want your patient to suffer. So I think we need to find that little niche, and I know it's hard. Individual patients take individual therapy, but we don't need to throw the baby out with the bathwater completely. We want to make sure that that troop or that retiree does not suffer because we were scared to write a prescription. We've got to do the right thing in a lot of areas, and so hopefully we'll get this right. So thanks for what you guys are doing. Maybe we could use this as a model for our civilian population. So I yield back, Mr. Chairman.
Thank you, sir.
Thank you, Dr. Abraham. Ms. Rosen?
Thank you, Mr. Chairman, and thank you for being here today. I have a couple of questions. One of my questions is about your prescribing. And so I know I'm from a physician family. My husband's a physician. He just had back surgery, and he's had a little bit of experience in some of these prescription issues. But are your models separating out inpatient drug use versus outpatient drug use? Because there's major and minor procedures. My husband had back surgery. Major procedure requires different types of treatment than someone coming in. So that's my first part of the question. And then also in regards with that inpatient to outpatient, how are you working with emergency rooms, not in our VA hospitals or in our treatment facilities, but in the general population to be sure that people aren't drug shopping by going to some other outpatient center?
Yes, ma'am. I'll take the ED one, and then I'll let Captain Colston talk about the difference with inpatient and outpatient, because you're right, there is a difference there. Part of our participation with the PDMP allows us now to have full visibility of people going to the ED for prescriptions, and even pharmacy, being able to see these pharmacies, the pharmacies that they attend or go to get their prescriptions filled. So we have a lot of visibility now on what we're doing. Our partnership with Express Scripts Since 63% of our patients receive their care from, or receive their opioids from civilian pharmacies or get the prescriptions from our civilian partners, they have provided us complete visibility of that as well. And they report to us when one of our patients reaches a certain threshold of opioid prescriptions and how much they're taking.
And they do that across all types of prescriptions because people can get multiple
Yes, ma'am.
drugs
Yes, ma'am.
that do the same effect.
Yes,
so.
ma'am. And as a matter of fact, part of our training has raised the awareness of some of those other multiple drugs, particularly benzodiazepines. And that's what we have actually seen a slight decrease in our providers avoiding prescribing benzodiazepines at the same time. So yes, exactly. We're tracking that very closely, and we have much better visibility of that now. As far as inpatient and outpatient, since Captain Colston is actively taking care of both inpatient and outpatient, so I'll let him.
Thank you,
I think
yes.
you were an outpatient, weren't you?
Right, but inpatient monitoring is different, and then you have to worry about when they become an outpatient as they transition, right?
Yes, ma'am. So a few things about inpatient care and major procedures. Of course, we use opiates. We use opiates surgically. We use them with other drugs. We use them with ketamine drips. We use them with nerve blocks. We use other pharmacological modalities to reduce the amount of opiate exposure that someone needs. Now, after a major procedure, say a coronary artery bypass graft or something along those lines, you get 10 days of opiates when you leave. That's an extremely painful procedure, and you've got your sternum cracked in two. And if you need another one, 7 days. But that's really at the point where we really need to watch you closely, because the thing that creates addiction is it's almost always iatrogenic. 3/4 of people who become addicted get it from medical intervention.
Right.
So it's very important for us to watch you in those types of situations. And the two variables that matter most are the dose, the amount of opiates that we gave you, and how long we gave them to you.
Right.
And an opiate use disorder is an extremely lethal thing to have. The 20-year mortality for that is 40 to 60%. So you turn an 18-year-old into an opiate addict, that person may not reach 40.
Right.
So we always need to weigh the risks and benefits when we start medicine. But opiates are definitely part of the medical care suite, and something that, of course, we want to deliver humane care, and we want to get to pain. One of the big things that we struggled with as physicians in the early 2000s is we just tried to get rid of pain no matter what the price, and we really created a number of folks who struggled and died.
Right. Well, thank you. I yield back my time. I appreciate your work.
Michelle Porter.
Thank you, and thank you for being here. I wanted to show you a picture of Daniel Keegan. Daniel Keegan was from my district, and he died from substance use disorder. And I wanted to tell you the story and ask you a couple of questions about him in honor of him and his mother, who is working very hard to let the country know that we have a problem and we have to do something about it. Daniel Keegan enlisted out of high school at the Dover recruiting office in my district. All he wanted to do was to serve his country. He was the type of recruit that we need many more of, incredibly smart. He scored an 800 on the verbal and 760 on math. He was well trained by our military. He was an impressive soldier. He attended the University of New Hampshire to further his military career. We have an all-volunteer force. We need people like Dan to stand up and answer that call to serve, as you well know. While serving, Dan developed a substance use disorder. DOD diagnosed him, was aware of his problem, but when he separated, he didn't receive any help getting into the VA system to continue treating his substance use disorder. In the time period after he separated, he struggled to get his comp and pen exam, relapsed, and then he died waiting for his appointment, which was not scheduled until nearly 16 months after he separated. His mother, Stephanie, shared his story with us. When he separated, Dan was struggling with this and was not equipped to navigate the VA system. Nobody offered him help. The DOD didn't offer him any help at all, even though they knew he had this problem. In Dan's words, he was a disposable soldier. We spent a fortune training him, but when he got sick, DOD dropped him. The VA bears some responsibility here. But it's clear from listening to Stephanie that Dan felt that DOD failed him. Dan loved the VA and wanted to help other veterans with their illness so they could access treatment. He would have been an incredible member of our community after separating from DOD, but he wasn't given the chance because DOD dropped the ball. He was not connected to DOD or VA service in a way that might have saved his life. In your testimony, you talk about all of the data that DOD has to identify at-risk patients. You have medical records that should show when a service member is being treated for substance use disorder. You also talk about coordinating care with VA, but you do not mention anything about what you will do to ensure separating service members get the health care that they need. I strongly believe that there has to be a system in place that ensures separating service members who are eligible for VA care and need VA care have an appointment scheduled before they separate from DOD. The command responsible for a soldier when he or she is separating should also be held responsible for making sure that soldiers receiving the health care that they need when separating. As I said, they knew what his problem was. Many separating service members are simply left in a position to navigate that whole system themselves, and clearly he couldn't. So I would like to ask you to respond to the following questions. What is DOD doing to ensure that there is no delay in getting care for separating service members? Is there any way that they talk to the VA or in some way make sure that there's a handoff, that we don't just leave them outside the door of the military? Can DOD employ case managers or coordinate care and ensure that his appointment is waiting for separating service members that are diagnosed either or are at risk for substance use disorder? And can we continue offering mental health care to separated service members when the handoff of a VA does not go smoothly and the service member is encountering significant delays in accessing VA care? I thank you for listening and would like to hear your response.
Thank you very much for sharing that, and it's very sobering to hear something like that when we've missed the ball on that or we've let somebody fall through the cracks. We do have quite a few programs that we recognize that we needed to be able to help transitioning service members from the DOD to the VA. And actually we have fairly numerous programs. I'd like to be able to give you a more complete answer if I could, to give you a list of some of those programs because I don't have them readily at my fingertips, so I'd like to take that for the record if I could. But if I may speak from a very broad perspective, DOD and VA have done some considerable partnering in recent years because we recognize that many of our patients are of the same continuum, and part of their care needs to transition from DOD to VA. We have recently agreed with the VA to share the same electronic health record so that we would be able to retrieve that information, the clinical information that's so necessary to understand how to make these handoffs happen more smoothly so that we don't create unnecessary gaps in their care. We've also been working at very high levels between the DepSecDef, Deputy Secretary of Defense, and the Secretary of VA to make sure that we're working on those strategic objectives, those strategic imperatives that allow us to be more seamless in our delivery of care. And then we also have several working groups and subcommittees of the DOD and VA to address several transition issues, whether it's health, behavioral health, or even in some cases, the ability to transition from working in the DOD to working in the VA health system. So if I could, I'd like to take that for the record so I could give you a much more comprehensive answer, but at a general level, we are working much more closely with the VA.
I appreciate that. So if a Dan was discharged tomorrow, would that system work, the one you just described?
Yes, ma'am. I think that what you've described and how his process went, I would like to think that what we've put in place would not have let that happen.
Okay, thank you very much. I yield back.
Thank you, ma'am.
So we're going to do a second round. My question is to active duty personnel who sustain some type of injury or require surgery where they're given opioids for a limited period of time. And let's say that active duty individuals is then returned, I mean, they are returned to their duty station, whatever it is. So they're not medically discharged, but severe enough to be given, to undergo a regimen of opioid medications or treatment. So let's say that because of that, they have a problem. And that they are seeking out opioids or drugs that they became addicted at some degree. So what tracking programs does the military have now? Do we still have, we have periodic urinalysis program. Would that pick up these opioids? Is that programmed to pick up the opioids? And at what level does it pick it up at? I mean, if somebody is not, maybe you tell me what the threshold is. If somebody's done it within so many hours, what is the threshold requirement that test could pick it up?
Yes, sir. I think in general terms, and I'll let Dr. Colston refer to the actual milli equivalents that we've set the threshold. Not only do active duty undergo routine screening, and for those patients that we've identified that are long-term opioid users, they are actually put on a regular regimen of urine screening so that we can monitor that. Yes, sir. The other thing is that we've also expanded our urine screening, urine drug screening, to include many more substances, recognizing that is a risk. But in terms of what the actual level, I don't know if Captain Colston might be more familiar with that.
Yes, sir. So there's the readiness testing that we do is totally separate from medical testing that we do.
Okay.
The readiness testing does have thresholds between positive and negative tests. It's extremely accurate. We have confirmatory testing, which uses very expensive linear chromatography, gas, mass spectrometry equipment. That's something that has nothing to do with health. And what we want to do is we want to treat these folks. We want to get these folks medication-assisted therapy. We want to, if they still have a pain disorder, we want to use for medication-assisted therapy a drug that also addresses their addiction, like methadone or buprenorphine. And we have any number of providers who are qualified to give those drugs. In fact, we have a surfeit of providers capable of giving those drugs. We have a policy on the medical side that we do not want to stigmatize any kind of addiction. We want folks to get treated. And in fact, at the partial hospitalization program where I work, command is kind of kept away for a little while as we focus on these folks, because in fact relapse is part of recovery for addiction, and it's such a dangerous addiction, opiates, that we really need folks to almost live in a vacuum away from command. And we've been doing that for 7 years there, I think, with great success.
So I think that my point is, so if somebody undergoes the regimen of treatment due to surgery or due to some injury that they've sustained, they then, you have a monitoring system for them post-election, post-prescription, or whatever you want to call it. And so nobody's going to fly under the radar from your perspective in terms of being...
The point I was trying to make, sir, is the readiness testing is not a way that we find people who are addicted. If we identify that you have an opiate use disorder, you're going to get regular urinalysis, you're going to get pill counts, we're going to check you for diversion, we're going to do any number of actions that help you get sober.
Mm-hmm. But the readiness test would indicate.
Yes. Oh, yes.
Yes, sir. I just want to add that readiness testing, the number of positive opiate screens is down 76% in the last 5 years. So we know that we're headed in the right direction on that problem, sir.
Okay. And how long have we been screening for opioids in that test?
Since the Nixon administration.
Oh, long time. Okay. Ranking Member Spear.
Thank you. Admiral Bono, you are embarking on an $81 million 6-year research collaboration. Can you describe your plans for the research, what population you're going to conduct the research on, and the extent to which you are going to implement your conclusions if they prove therapies, if they prove effective before the actual research is completed, or are you going to wait the 6 years?
Yes, ma'am. So we have several ongoing research collaboratives. One of the most robust ones is with West Virginia and also with NIH. So what we do with both of these collaboratives is we make sure that as we see results and they get validated, and this is the important part of the research, is being able to address certain aspects of opioid addiction and treatment. And once we get validation and we know that it's effective, we try to put those into place right away. As a matter of fact, Captain Colston and I were just remarking that in the last several years, since 2015, because we've started seeing the results of some of this research, we've been able to put in many of those practices and those treatments that we've understood better because of the research, and that's been happening in the last few years. So I anticipate that as we continue this level of effort, that we will be able to implement things much more quickly.
Let's see, Dr. Abraham, I understand nothing. Ms. Shea Porter, nothing.
Mr. Chairman.
Go ahead.
I read an article that suggests that the use of marijuana reduces the amount of opioid usage in those areas that have legalized marijuana. I realize the federal government's not one of them, but I'm curious if you've done any research on that. It was Medicare patients use fewer opioids with medical marijuana laws was the headline on this particular article.
Yes, ma'am. We're always monitoring other aspects of care and seeing if there's scientific evidence-based data that would help support that. So we're monitoring that. We don't necessarily do that research, but we monitor everybody else's research.
And if in the end it's found to be helpful, what do we do about it?
Well, I think that would be something.
I guess that's our job.
Yes.
Okay, I yield back.
I was going to ask for help on that one.
I think you would need it. I wish to thank the witnesses for their enlightening testimony this afternoon. There being no further business, the subcommittee stands adjourned.